Inaugurating our 19th year of continuing education courses on tape, this is Audio Digest Surgery, Volume 18, Number 1, for the week of January 13th, 1970. This week, a spirited, sparring panel of experts whose frequently divergent viewpoints exemplify the controversies in managing breast cancer, in particular, the years-long debate over radical versus conservative therapy. Our consultants this week, the Cleveland Clinic's George Cryle, Jr., one of the most outspoken advocates of simple mastectomy or local excision, Guy F. Robbins of New York City's Memorial Hospital for Cancer and Allied Diseases and Cornell University Medical College, who favors radical mastectomy, and Bernard Fisher, chairman of the National Surgical Adjuvant Breast Project and from the University of Pittsburgh School of Medicine, who stresses the need to reserve judgment regarding the best surgical approach until definitive data becomes available from properly conceived and executed clinical trials, something sorely lacking at the moment. Program moderator and first discussant is Temple University's George P. Rosemond.
My portion of this has to do with a discussion of diagnosis. We have various ideas about diagnosis that have been promulgated, and it's a rather strong feeling of most of us at the present time that if we would really use our presently known diagnostic methods, and I hope we'll have better ones fairly soon, that we would be able to attain a potential 10-year survival rate of somewhere around 70 to 75%. Now, it's easy to say that because nobody has ever fully used this potential, and we don't have any such survival rates to report. But nevertheless, in spite of that so-called flat line that science writers keep referring to, we are doing better in large series groups than we once did by using the various methods of diagnosis available and the various methods of treatment. Now, in the first place, we all know that the patient ordinarily finds the lesion first. In our Philadelphia series, we started out with a patient finding the lesion approximately 92% of the time and calling it to the attention of the doctor. And sometimes the doctor was too dumb to know what he was looking at. We'll admit that. But that did happen. It may happen in other areas too. We found after a number of years that that percentage figure was dropped somewhat and was down to around 88% after about 10 years, democracy moving very slowly in this direction, which means that doctors were picking up a few more of these lesions on routine examinations in our area. Of course, what we really have to do is to have patients call attention to a potential lesion and have doctors use the criteria that they should know about and be able to use to make the diagnosis. Now, what does a woman look for when she is examining herself? Very early Paget's disease is when Paget's disease ought to be diagnosed, when it's so small that it's pretty hard to find. There's a very slight erosion, looks like a pinprick in the middle of the nipple, and that's the time to pick up Paget's disease. It's highly curable then. It's a killer if delay occurs. Now, spontaneous discharge from the nipple is a sign of possible tumor, although most of these are due to benign conditions. If it's not spontaneous, it's not important. If it's cyclic, it probably isn't very important. If it is spontaneous, it may or may not mean carcinoma. Usually doesn't, but in the older age group, there's a very high percentage of carcinomas in this type of person. And of course, a smear of this is sometimes helpful. Now, most breast lesions are cysts, especially in the premenopausal female, occasionally in the postmenopausal one. And they can be not only identified, but cured by aspiration in most instances. I think that you should use a skin wheel for anesthesia because I believe then you'll be able to be more deliberate and more gentle in your aspiration of the cyst, therefore more accurate. Aspirating the fluid, and generally it's rather nondescript and quite thin, comes out through a fairly small needle. Sometimes these cysts will promptly recur, so we always follow these patients carefully for a short period. 2 to 4 weeks, they should be re-examined. If the cyst is recurred and is tense, as it is in the beginning, then it should be operated. And you'll find occasional cystadenocarcinoma and occasional cystadenoma. One of the real adjuncts in recent years to the evaluation of the patient with a breast complaint has been mammography. It is important, even if you've got a lesion palpable in one side, to use mammography as part of your total evaluation. and you'll occasionally make a rather brilliant pickup, although careful examination of the patient usually finds the lesion. The postmenopausal woman, they're ideal for mammography. Skin retraction, of course, is extremely important, and I will make no further comments about this at this moment. Question and answer period. Management of persistent nipple discharge localized to one quadrant. Well, that's a fairly simple question, because we do explore the nipple and we do quadrant resections. Ordinarily, if it's limited to one segment of the breast, then you'll have discharge from a solitary duct. Now, this can be ominous, and this duct should be explored and the segment removed if a definite lesion is not identified. Do you subject breast cyst aspirant to cytologic study? No, we stopped that a number of years ago because we found that we were merely feeding the Department of Pathology. We got negative results back consistently, and we don't think it's worth it. It's rather unusual to find a cyst adenocarcinoma or a cyst adenoma, but it does occur. When it occurs, the cyst promptly refills. That's when you need pathology, but you need excisional pathology at that time. In a premenopausal woman, how long may one continue to aspirate recurrent cysts? Indefinitely, I would say. We do not aspirate cysts that are fluctuant. If you have a firm cyst that you can't differentiate between a cystic or a solid lesion, they should be aspirated to determine this. If it's a solid lesion, it should be promptly operated, just as you would any other solid lesion suspected of being carcinoma. If it's a cyst, it should only be operated if it reappears within the next several weeks. We follow them sometimes 2 weeks, sometimes 3 weeks, sometimes a month. But in that period, they should be followed. If you have a firm lesion again appearing in that period, or if your cyst aspirant is bloody, then we feel that excisional surgery for biopsy purposes is essential. So we'd continue to do this indefinitely as long as these cysts appeared and we couldn't tell them from a solid lesion. Here's a question that has several parts. What to do in 6 months pregnant female with questionable solid lump? No radiologist will do mammograms. A couple of question marks. Don't know that they won't. But I suppose the first part of this is 6 months pregnant female with a lump. It depends on how questionable it is, of course, in every case. But if there is a lump there and you think it's there, it should be biopsied, no matter whether the woman is 6 months pregnant or not. It's our feeling in our institution that cancer of the breast in the pregnant female should be handled as promptly as possible. And if nodes are not involved, that they have a reasonable chance of survival. So we handle them just like a person who is not pregnant. Possibly you'll need a little more blood in the operating room because they are vascular, of course. Now, as far as no radiologist will do mammograms in a person who's pregnant, there's no particular reason why they won't. As far as I know, I'm not a radiologist, but I don't believe that they irradiate any vital area to the fetus. That's the impression that I gather from the radiologist in our institution. What do you do for patients taking off birth control pills? She complains of specific area of pain in the breast. Well, that's a pretty difficult one to answer, but the dose that's given for the birth control pills usually doesn't affect the breast a great deal. It might give them the same symptoms that they get premenstrually, and so usually it's the other way around. If they're put on birth control pills, they might tend to get various pains in the breast, but this can work both ways, as you well know. Now, the next member of our panel, Barney Crowell, will give you his own topic.
I'm not going to even discuss supraradical or conventional radical mastectomies because I consider this to be whipping a dead horse. And I do not believe that there is any question but that the randomized studies done in Scandinavia and in England have shown first that there is no difference in 5 and 10 year survival rate between ultra-radical mastectomy and the ordinary conventional simple mastectomy with radiation. There is no difference between the Hay-Biddle's work, no difference between in stage 2 cancer, conventional radical mastectomy, or modified radical, or even sometimes very simple, in which practically no attempt was made to dissect the axilla. In both of those, radiation was given postoperatively. And we've also found that radiation recently doesn't alter the prognosis. So I'm sure it's safe to say, as practically all authorities now agree, that between the modified radical, the radical, and the superradical, with or without radiation, that's prophylactic radiation, there is no advantage from the standpoint of 5 or 10 years survival. Now, that being the case, the next problem is, what problem is there? And here we come to unpleasant considerations, because there is abundant immunologic evidence that I'm sure most of you are familiar with, and many of you have heard me speak of, to indicate that if regional lymph nodes are not involved, their removal diminishes the systemic immunity to that particular type of cancer implanted in the form of metastases elsewhere. In other words, the regional nodes, if involved, obviously have no immunological potential, so it does no harm to remove them or to radiate them. But the uninvolved regional nodes are uninvolved because of that immunological potential, because it is quite obvious that the cancer is not a localized disease ever, that in practically all cancers that are capable of metastasis, that cancer cells are entering bloodstream and lymphatics, and that they are being destroyed elsewhere in the body. And so what I would like to speak of is to go on just a little bit from this point of view, which you're already familiar with, and to speak about two things which are different. One of them is, of course, is even a mastectomy required? Or can what the British, I think, poorly call lumpectomy suffice? Now, lumpectomy implies that one excises only the tumor. Of course, this must be used in patients who have lesions that are peripherally placed, and lesions also that are small. And so they're selected to begin with, and it's impossible to make valid comparisons between the removal of the local tumor and the results obtained by mastectomy. All you can say is that what we consider quadrant excision of the breast, in which about a third of the breast is removed along with the tumor and enough skin overlying it so you have practically as much as you would in an ordinary mastectomy, overlying and surrounding the tumor. When that is done, in our experience, pending publication by Dr. Stanley Herr and myself, in some 56 cases, which represents about 10% of the breast cancers operated on at the Cleveland Clinic since 1957, in this group, there has been a survival stage for stage, which is entirely equivalent to that obtained by mastectomy. And not only that, but the recurrence rate locally has been identical in stage 1 and an extremely low, only 5%. And in the entire group, there is no instance of a recurrence in the breast tissue itself. The local recurrences have been, as elsewhere, it's been involving such things as skin and axilla and so forth. Now, the question then are twofold, and biologically, I would like to review with you very briefly, not the animal experimentation, which I'm sure that you're familiar with, that susceptibility to reimplantation of the cancer is increased when one removes regional nodes, but the result of our clinical experiments. And we have been doing this now since 1957, when we simplified our treatment. This is the treatment of breast cancer at the clinic, 57 through 64. These are the operable patients. Radical mastectomy was only done in 1%. Modified radical, that's axillary dissection in continuity with breast, but leaving the muscles, in 45%. Simple mastectomy or local excision in 54%, and cobalt was given postoperatively in 21%, mainly in those who had extensive disease, and the axilla was considered to be inoperable, and therefore we backed out of the axilla and treated with cobalt after a simple removal of the breast. Now, what were the results in this group? That was the proportion treated in each way. The crude survival, that's all patients entering any department of the Cleveland Clinic with hitherto untreated breast cancer, was 59%. In the operable stage 1 and 2s, it was 72. Everybody has an occasional patient who's dying of something else and has an incidental breast cancer, and you don't operate on them. Stage 3 and 4, only 13%, which shows that we weren't selecting very carefully, or that would have been higher. And the local recurrence rate at 5 years was only 6%. These figures all stack up against figures anywhere, although it is absolutely valueless to compare one institution's figures with another, as everybody knows. Now the ones that I'm interested in, because we have more control over this, we have two groups of patients. One of whom was treated by simple mastectomy with no radiation, but we were wrong. We didn't think there was anything in the axilla, but there were nodes in the axilla. The axilla, by the way, is always explored at the time of our simple mastectomies and palpated, because you're 3 times as accurate when you explore it at the time of operation as you are if you do it from the outside. So there aren't many of these cases. But there is simple mastectomy, no radiation, but later on, average 22 months, nodes appeared and were dissected and proved to be positive. Similarly staged at the time of operation, the surgeon thought there were no nodes involved, but he did a modified radical mastectomy prophylactically. Average number of nodes was comparable in the two groups. Only one node was actually involved more frequently in the ones who had the delayed dissection, showing no tendency of the tumor to spread from node to node during that period of 22 months delay. And the survival rate was identical practically in the two groups, showing that no harm was done by picking up the disease later, the way many people feel they should do with melanomas or with cancers of the head and neck. Now, an interesting one, all of these are invasive cancers, and we eliminated the small ones in order to avoid difficulties of any kind, so the survival rates are a little bit low because some of the most favorable ones have been eliminated, or there would have been heavy weighting in favor of simple mastectomy. Average size of the tumors in the two groups are the same. The average age of the patients was similar, but tremendous disparity. 70% and 85% survived 5 years, and I would feel much better if this were 80%, because this disparity may have something to do with selection that I can't put my finger on, but I still think the difference is too great. But anyway, the results were much better in these in whom we did just simple mastectomy when no nodes were involved. Now, to show that a 5-year figure is valid in respect to these two, our 10-year survival curve between simple mastectomy and modified radical shows that the difference at 5 years is even greater at 10 years in favor of the simple operation. Now, this is the clinical side of mastectomy, and I think there is no question that throughout the world the swing is towards the simplified treatment. Whether you could go immediately to any kind of simple mastectomy alone, or whether you should just adopt a modified radical at the present time, I don't know. But the last survey of Britain showed that only 20% were doing the standard Halsted operation. They apparently have taken heed of their own randomized experiments and followed it. But the great question, and the one that fascinates me at the moment, is whether or not even the primary tumor should be removed when you first see it, or whether it should have a preliminary treatment with irradiation. I'm talking now of the loss of concomitant immunity, and I'm sure that you all know that in animals and man too, spontaneous tumors induce an immunity which make it difficult while that tumor is still there to reintroduce the cells of the same tumor elsewhere in the body and have them grow. It might be wise in some types of superficial tumors to give a localized destructive dose of radiation prior to the operation in which the entire radiated and tumor-bearing field is operated on.
We've had a number of questions addressed to this panelist.
My first question was, are you kidding? And I think that's a very good question to speak to, because I'm perfectly sure that some people are so fixed in their thinking that they would think it inconceivable. But I do believe that they have to remember the Hadley survey last year showed that only 20% in England of the surgeons are doing radical mastectomies. And this is a survey of all Britain, of the conventional type. And I think that it has been already established in England and Scandinavia that there is no advantage to the conventional operation. Now, please do not failed to distinguish between a modified radical mastectomy, which removes the axillary contents, and a simple mastectomy. I cannot say with assurance that a simple mastectomy is any better, and certainly it gives some worries and follow-up. But I think it's something that has to be considered by all of us. But I am certain of one thing, and that is that there is no longer justification for the side effects of the radical, and particularly with radiation. I'm right with Fisher, because it has been proven already not to be any better than the regular. In honest, if your wife or daughter has carcinoma of the breast, what is your choice of operation and adjuvant therapy? My former wife had a cancer of the breast. She had a simple mastectomy. She had no radiation. She had no lymph nodes ever appear in the axilla, and she died 5 years later with cerebral metastasis. And she had comfortable, very 5 years, because she had a simple operation not done by me, but by one of my associates. Go on through some more. All right. They said, why is your local recurrence rate 5% after lumpectomy? With a radical mastectomy, you should be no recurrences. Of course, there are recurrences always at every stage, but not only that, this is clinical staging. So 30% on clinical staging, as you know, of the axilli that you gauge as negative actually have nodal involvement. The next question is, how many surgeons at the Cleveland Clinic concur in your philosophy on breast cancer? I don't suppose any do exactly, but no more radical mastectomies have been done. There hasn't been one done for 7 years, and only 1% in the last 10 years. So nobody is doing that. Now, Dr. Herr and I operate much the same. Dr. Esselstyn does local excisions too. Dr. Herman will do a certain number of simples, but mainly he does modified radicals.
This is a rather odd question. It says, does any reputable surgical figure in this country, besides Dr. Crowell, so this is a very high compliment to him, support the concept of limited mastectomy and irradiation? I would say that quite a number do in this country. This has been a controversial subject. I think the majority of surgeons at the present time feel that radical mastectomy and sometimes the variations of radical there certainly is the most frequently used. But maybe Dr. Crowell himself would like to make a comment on that.
Well, if we just do a quadrant excision, which is a partial mastectomy, we don't remove just the lump. We don't do anything else. We don't irradiate if it's a clinical stage 1. Only if it were a clinical stage 2 would we irradiate or maybe do an axillary dissection with it, depending on the individual. This is a very long and complicated thing, how to handle these small peripheral lesions. But I can assure you that there is going to be more and more of this done, because this is the international trend and it is successful. Can you support immune response to cancer? If yes, how? Well, of course, this is completely established in animal cancer, and I think that the work of Southam and Brunswick is incontrovertible. That it's almost impossible to, at least it's rarely possible, to transplant a cancer in a person who has one to another part of his body unless he's under immunosuppression or in terminal phases of the disease. It's difficult to transplant it. Now, this one is, if the body really develops immunity to cancer cells, why doesn't it destroy the cancer cell before it gets started? This is like everything in immunology, a quantitative affair, because it's like an enemy sneaking in and building a missile station and getting it all built before you realize it's there and then starting to shoot at you. A very small number of cancer cells do not evoke an immunologic response. The response depends not on time, but on size. And so that's what happens. It just sneaks up. It says, why leave tumor in to provide immunity instead of totally removing so immunity will not be required? This is the point. We're treating microscopic disease with macroscopic means, as has been said. And when we say remove all the tumor, we don't remove the last cell. These cells are circulating. And that's why you have to provide for maintaining immunity as long as possible in order to get rid of the circulating cells. You also, of course, have to remove gross tumor. But we forget the invisible tumor. How do you know axillary nodes are involved? You don't know they're involved. You're wrong 30% of the time when you examine them clinically. But if you're willing to make your incision in such a way with whatever operation you do in the breast that it goes under the hairline and you break into the axillary space and roll the fat pad, the consistency of these nodes, the beating of the lymphatics, and so forth, will reveal itself and positive in 7%, according to our present figures, instead of in 30%. So we are rarely now having to reoperate on people because we missed the first time. Of course, we do occasionally take out a node which we thought was involved, but which wasn't. I have two questions which show the fundamental difficulty of the surgeon who is schooled in radical mastectomy to consider a variation of techniques. Breast cancer has meant radical mastectomy. It's still not clear to some people that we only do less than half of the operations as simple operations without axillary dissection. And so we have two questions. Do you remove axillary nodes if palpable, while simple mastectomy for stage 1? Of course we do, if they're hard and we think they're enlarged. Because none of us believe the cancer just goes away. We have to treat cancer in nodes if it's there, and we know it's there. It's when it's not there that we don't know whether it's a good thing to treat it or not, or at least when you can't feel it there. And would you venture to say that all radical node resection for cancer anywhere is futile? Of course it's not futile. How could it be? You all know that a great many people are cured by node dissections, and we advocate node dissections. But there's a very interesting thing, and that is whether by radical or simple operations with radiation, our incidence of clinical stage 2 cancer patients who are surviving at 10 years is only 9%, and it's identical whether treated by a axillary dissection or by a axillary radiation. Have you any long, 15, 20 years survivals of small operations for small tumors? Of course. At 15 years, our series only goes back 15 years, but there are just as many associated with small operations as there are with large ones. Do you do a biopsy before you remove a quadrant? If there's any question, I mean, if it's quite certain to be a cancer in an older woman, we can do a quadrant resection without that. But in a younger woman, we do, and we usually do them as in and outs without hospital reservations. Do an excisional biopsy if it's small, or an incisional if it's large, but then let the wound heal up before we go at it again so that we won't break into the clot and contaminate the wound.
The conclusion of Dr. Kryle's presentation on modified radical mastectomy versus simple mastectomy or local excision also signals the end of this side of your program, Doctor. On side B, Guy F. Robbins provides some pointers in managing breast cancer patients. Bernard Fisher discusses surgical adjuvant chemotherapy. And all participants join in providing some concluding remarks. And to hear this, just flip over the cassette or 2 reels on your tape recorder. This is Side B, Audio Digest Surgery, Volume 18, Number 1, continuing a program on controversies in managing breast cancer. Once again, program moderator George P. Rosemond.
The next speaker on our program is Guy Robbins.
I guess I represent that rather large and sometimes inarticulate and often not silent majority who has never been able to really put themselves in the spot where they say that they can tell with their fingers what's going on in the axilla. We don't have any microscopes in ours. We also are very leery, I must say, of malpractice. And therefore, we haven't got into many of these things that I'm sure are very interesting, and we're sort of plugging along. Now, points that I want to bring up may help you, they've helped us, in the care of our patients that have breast cancer during the 70s. The first is the work that has been done with Jerry Urban as the leader on biopsying the second breast at the time the first breast is done. There is a pickup, and I think as time goes on more and more with the work that Gallagher's done and others, cancer of the breast must be considered quite frequently, if maybe not always, as multicentric in origin. There's been some material in the literature about the importance of doing a bone scan preoperatively. Now, we haven't done bone scans preoperatively, but what we have done is if a patient has symptoms, we will do scans or skeletal surveys, and occasionally you do pick up something. So what we did was go back to our 1960 patients and reviewed those that were infiltrating operable carcinoma, and with a 9-year follow-up, ascertain how many of them did develop bony metastasis. There were none in the in situ lesions, so all of this is restricted to the infiltrating cases. We found that 61 of these patients did develop bony metastasis during that next 9 years. Now, it just doesn't seem practical with bone scans in the New York area at $150 a piece to do 321 bone scans preoperatively and come up with this kind of a take, some of them not developing for quite some time. And in addition to that, we're not quite sure if the treatment had been different, if they would have done any better. I guess we'll need a real fancy prospective study on that one. Then, of course, we tried to ascertain, is there any guideline you can tell as to who's going to get bone metastasis? And the only thing that we came up with, that it seems that those patients that have a histological greater stage of disease at the time of primary therapy are likely to get them, but there were fall-throughs on that, too. We're getting a little bit of stuff on delay there at Memorial Hospital in our cases that we did in the 40s, the 50s, and the 60s. We are seeing, and certainly this isn't an epidemiological study because people come in the front door for many reasons into many hospitals, so this certainly isn't a population affair, but there are a lot more that are coming in with 2 cm lesions, and there are less that are coming in with enlargements. And then the size of the lesion, there are more small lesions that are showing up when we see them. And we tag our axillas, level 1 being those nodes close to the axilla, the breast, 2 in the middle, and 3 at the apex. We're getting more negative nodes, more with nodes at levels 1, and less with those at level 3, which is at the apex. Now, there's been very little talk about quality of survival. And I'm sure that there have been some radical mastectomy patients that have been a mess because of that big arm. There have been some that have had X-ray therapy following a simple that have been pretty well messed up. And the attitudes of patients, the attitudes of physicians, the attitudes of the allied health professional and all those, we feel those things are very important. And the College of Surgeons now, as you probably are aware, is going to include quality of survival data in their registries in 1972. Now, last year, Dave Schottenfeld sent out a random sample of questionnaires to 826 of our patients, asking about how were you before, how long did it take you to get back to work, and the kind of things we think is pretty doggone important. And we were surprised that we did get back 77% of a questionnaire. This is a pretty good-sized return on any questionnaire. We found that 44% of these patients had been employed part-time or full-time before. The other 54 were doing housework and such. And 2% did have limited activities. We found that those patients surviving in 5 years, there were 84% of them doing what they did before they had their radical mastectomy. 10-year level, 91% of those were alive, were doing what they did before, and 15 years, 88%. We think this is important. This whole article was in Cancer last month. And I think that all of us are trying to have guidelines for how do you help these people have a better quality of survival. It may come out that once we do find some type of a way that we can really tell whether those axillary nodes are involved, we'll be able to do less surgery. I remember Fred Stewart back in the 40s took 100 mastectomy specimens. He dissected the axilla himself, looking at the nodes. And he called, this is positive, this is negative. He was wrong a fourth of the time after he had all that fat out of there, everything else. And as far as I know, most clinicians in England, Dr. Higginson, Witt Memorial, are wrong about a third of the time on this by doing a clinical inspection. And along the lines of the quality of survival, the College of Surgeon people, I'm sure, are familiar with what the Cancer Society is now doing in this Reach to Recovery program. It is now under medical supervision, and there is something to this to get help from those that have had a mastectomy. We're using it at Memorial in connection with a sort of an Alcoholic Anonymous class where the girls who've had the radicals are talking to each other. We have our social workers there with them and physiotherapists and the nurses. We give our patients a record before they go into the hospital that has a whole lot of dope on. First thing it does is congratulate them on making their mind up to do something. Then it tells them about advised consent, how long they're going to have to stay in if they have a little operation or a big operation. Not talk to their next door neighbors because they may get scared to death. Insurance, all this sort of thing. Then we have another record that's been developed. There have been about 2,000 of these go out. There's 3 gals who've had a radical 4, 8, and 15 years. They tell about the things they go through. These patients take these home and play them. This helps the husband and the rest of the people understand what's going to go on. This helps the family to do a better job once the woman does get home. Now, these records, anybody who wants one can write me at Memorial, and I'll send them to you. We haven't had them merchandised. We tried to get a couple of companies to do it, but as much as there are just a few thousand women with breast every year, apparently they didn't seem to think this made much sense. But if you write me, we've got a good supply of them, and we'll send them to you. Another thing I want to put in as a plug here, the book, The Ecology of the Cancer Patient. The MD Anderson got three-day sessions together under the auspices of the Smithsonian Institute and the New York Academy of Science on rehabilitation. They took up breast, extremities, many of these other things, and I strongly urge you to try to get a hold of it. You can get it from the Smithsonian Institute for $1.25, and it's really got a lot of good stuff. I've tried to segregate the questions into general topics. The second biopsy. This biopsy is done even though we don't feel anything, and is done in the mirror image. Now, as you know, most lesions are in the upper outer quadrant, so that's usually where they fall. However, if it isn't in the upper outer quadrant, we will frequently do mirror image plus the upper outer quadrant. Some more questions come, and a number of them are considered with the second breast biopsy, and when should you do a simple on the other side? On the second breast biopsy, we pretty much are doing on all our patients now where we get a positive for carcinoma. You just can't let something go when the yield has been as high as it is, and of course the important things are early cases. Now, when do you advise a simple? One question came up and said that relatives, a lot of the girls in the family had it. What would you do? I think with the high-risk patients, this is certainly something that's got to be considered. Henry Lee's in New York is doing it. We've found that a number of our patients don't want to let go of those breasts. And I think it's still open. There's no doubt that there is a great deal of unnecessary surgery if you do this. But in the work that Berg and I did a number of years on long-term follow-up, we found those patients that were between 45 and 55 that had nodes limited at a maximum level of 1, where the lesion was 2 cm or under, there were at least a fourth of them that lived long enough to get breast cancer. George Pack recommended this years ago, and I think it's something that hasn't been answered, but certainly I don't think there'd be any malpractice in this thing if you did it in the situation that was brought up here. Technique, what do you think of thick flaps? I think the important thing is to get the breast tissue out. And we do not do paper-thin flaps, but we try to get down to that first layer of fascia, which isn't very, very deep. However, as we go farther away from the breast, we may make our flaps a little thicker. But a total mastectomy, and whether you do a simple or a radical, is so important, and I think one must consider a total mastectomy to include taking the lower axilla, because anatomically the tail of the breast does extend somewhat farther than many of us think at first view. So I think to take the tail of the breast and take a little of the axilla, if you're just doing a simple, is essential. A question brought up on bone marrow. Should the bone marrow be done instead of a scan, and would this give more information? I think this is a good question and one that we haven't answered, but it's certainly something that should be considered. We're doing it, but not in as regular a way as we can. Certainly you'll find positive cells in the bone marrow where you won't find them on a scan or on a skeletal survey. The treatment of lymphedema of the arm. The best way to treat it is not to get it. And I think it's cut way, way down since the radiation therapists are not giving a direct axillary port. This certainly changed ours at Memorial. One of the important things, and we give away a list of do's and don'ts to patients about the care of the arm post-operatively. And we repeat this and repeat it and repeat it, because it's these secondary infections that seem to stir this stuff up, and as you know, it can happen many, many years later. A couple more questions have come up on the utilization of a radical mastectomy at Memorial. On those patients with in situ carcinoma, we are doing the modified. And the reason for that is that from time to time we do find an infiltrating lesion that's so small, and we have found several times where our frozen sections in situ, we get back the report of positive axillary nodes. A question was brought up about removing the breast, leaving the nipple, and putting in a prosthesis. We are doing this on some of our in situ lesions. We haven't done enough to really come up with any definite conclusions, but I must say that one must very carefully psychiatrically screen these patients, because this thing doesn't feel the same in bed as some of these people think it's going to. And you can get a lot of trouble if you don't spend some time on a psychiatric evaluation of these people.
The final panelist is Dr. Bernard Fisher.
Surgical adjuvant chemotherapy would seem to offer the most likely means of escape from the plateau on which the salvage rate of breast cancer has been ensnared for 30 or more years. What have we accomplished to date? You undoubtedly recall that in 1958, National Surgical Adjuvant Breast Project, hereafter referred to as the NSABP, undertook a study to evaluate the worth of short-term adjuvant chemotherapy. It was found that Thiotepa in general failed to enhance the benefits of surgery. In any subgroup of patients that you might take, the use of Thiotepa and the control groups were both the same. Closer examination of the data did reveal, however, that in premenopausal women with 4 or more nodes involved, there was about an 18 to 24 months delay in the occurrence of treatment failures. 5-FU was ineffective when so used. Consequently, there would seem to be no justification for the use of such short-term therapy as a surgical adjuvant. New and better protocols are prepared which take into consideration the evidence that tumor cells may be sensitive to certain drugs during only a part of their cycle, which may be variable and prolonged. Consequently, the prolonged administration of a chemotherapeutic agent and or the use of combinations of drugs is undergoing consideration. Similarly, the employment of immunotherapy, particularly non-specific immunotherapy, and certain hormonal agents alone or in combination with chemotherapeutic agents warrants consideration relative to their evaluation within the framework of a cooperative program. Now, since 1889, when oophorectomy was first proposed as an adjunct to the surgical treatment of breast cancer, its worth has remained uncertain. Because of this, the NSABP in 1961 initiated a randomized clinical trial to evaluate surgical oophorectomy as an adjunct to radical mastectomy for the treatment of operable breast cancer in premenopausal women. Essentially, what this study has demonstrated that at the end of 5 years, patients who were oophorectomized or all controls had the same disease status. That is, the percent of treatment failures was essentially identical. When this was broken down into negative node patients or positive node patients, likewise, there was no advantage for those oophorectomized. And if one plots this in life table fashion, one can find that insofar as negative node patients or positive node patients are concerned, there is no real advantage for those who have oophorectomy at any of the times. Survival rates, the same thing. Oophorectomized patients, essentially the same survival rates as controls. And if these are considered in negative node categories or positive node categories, again, oophorectomy poses no advantage. And once again, life tables of survival for premenopausal patients demonstrate essentially no advantage at any time for those oophorectomized. In conclusion, findings have failed to demonstrate that prophylactic oophorectomy was beneficial, as evidenced by treatment failure or survival. No evidence was obtained to indicate that this procedure conferred an advantage by lengthening the time from surgery to recurrence, nor did it delay death. Consequently, there would seem to be no further justification for its use in the treatment of operable breast cancer. Its use therapeutically in advanced cancer is not contested. And surely it must be considered a travesty of our time that it has taken almost a decade of cooperative effort to gather together a few hundred patients for a critical evaluation of a modality the worth of which was uncertain for 80 years. For almost 3/4 of a century, there's been uncertainty concerning the merit of postoperative radiotherapy as an adjunct to surgery. There have been those who presented evidence to suggest its value. Others have found it to be of no worth. Again, prompted by this therapeutic uncertainty, the NSABP in 1961 initiated a randomized prospective trial to assess its worth. Results have just become known and will be published in detail in this month's Annals of Surgery. Postoperative radiation was given to internal mammary nodes, apex of axilla and supraclavicular region. If one considers the disease status 60 months after surgery for all patients entered, one finds that 51% of those with radiotherapy had no evidence of disease, 50% of the controls had no evidence of disease, and consequently, approximately 50% of both groups showed treatment failure. You notice I don't use the word recurrence, I use disease status. If we break this down into patients again with negative nodes, we find no evidence of disease in 79% receiving radiotherapy, 6% of controls. Conversely, total treatment failures, 21% radiotherapy, 24% controls. Positive node patients, again, 38% showed no evidence of disease following radiotherapy with 32% controls, not a statistically significant difference. If one considers the location of the first evidence of treatment failure for all patients, either local, regional, or distant metastases, one finds that indeed the radiotherapy group did show a very slight but insignificant decrease, but the greatest advantage was in the decrease of regional recurrence, and there was some suggestion that distant metastases were increased following radiotherapy. If one examines this information further, breaks down the local recurrence into chest wall and scar, we see that indeed radiotherapy was beneficial in preventing the recurrence in the scar. It was also beneficial in reducing the percentage of treatment failures in the supraclavicular nodes. Evidence of disease following radiotherapy in life table plot lines are quite similar. And if one considers survival, at the end of 5 years, 56% of radiotherapy patients surviving versus 62% of controls. And if again we examine this according to nodes, 74% radiotherapy, 79% controls in the negative group. And here positive node patients, radiotherapy, 47% surviving versus 50% in the controls. And according to menopausal status, no advantage for radiotherapy in premenopausal patients, no advantage for radiotherapy in postmenopausal patients. A life table plot of survival again demonstrates no advantage for radiotherapy. It would thus seem that the use of postoperative irradiation has provided no discernible advantage to patients so treated in terms of increasing the proportion who were free of disease for as long as 5 years. While its use did decrease regional recurrence, the apparent increase of treatment failures due to distant metastases as first evidence of disease and the lack of improvement in survival fails to support the worth of irradiation as an adjunct to surgery in the treatment of operable breast cancer. Up to now, I've discussed surgical adjuvant therapy. Adjuvant to what kind of surgery? Incredible as it may seem, there is existing uncertainty concerning the proper surgical treatment of clinically curable female breast cancer. As you have heard, in this country and throughout the world, a woman with such a tumor may have a surgical procedure ranging from a lumpectomy to extended mastectomy, depending on the belief of her surgeon, which all too often has been synthesized from an uncritical acceptance of results from poorly obtained and meaningless data, or because he has mistaken popularity for excellence. Despite the plethora of publications that have appeared over the years, it's my judgment that it has not been clearly demonstrated that any of the alternative surgical procedures, either those that are more conservative or those that are more extensive, should or should not supplant radical mastectomy. I'm not saying that such operations may not produce as good or better results. Well, they might. What I am saying is, and as disquieting as it may be, adequate and proper data are not yet available to make judgments and conclusions in that regard. The findings of Crowell, McWhirter, Urban, and Patey, and others concerning simple mastectomy, modified mastectomy, and so forth have resulted in polemics that for the most part are senseless and uncalled for. These investigators...
I didn't hear him, but he must have been nasty.
These investigators have primarily, as a result of retrospective analysis of their experiences, provided suggestive evidence that other surgical modalities may be equivalent. The resulting controversy is primarily due to a failure to view such studies in their proper perspective. The trouble is not so much with the studies as with those who have ascribed more or less validity to them than they deserve by failing to recognize their purpose and limitations. Such retrospective analyses must be looked at in the same way as animal investigations, just as their prime purpose is to provide guidelines and clues as what to be expected to occur when such studies are applied to the human. So may the retrospective study apply hints for future definitive evaluation. Consequently, as a result of such suggestive evidence from many sources, it becomes obligatory to obtain definitive data through properly conceived clinical trials. Dr. Crowell, McWhirter, and others have always called for such studies. In such studies, similar patients are randomized so that one group receives the therapy to be evaluated, the other receives standard therapy. This is the scientific method for which there's no substitute, and I contend that no longer can we justify the haphazard manner by which we slip in and slip out of one therapeutic regimen after another. For almost a decade, efforts have been persistently exerted to properly evaluate the worth of total mastectomy with and without of irradiation. This is not only because of the suggestive clinical evidence, but more importantly because biological information warrants this. Such a study has wider ramifications than just those related to breast cancer. It involves the first reassessment of surgical principles for cancer since Halstead's time. Well, I could go on and on here. One of the questions I have, insofar as place of prophylactic mastectomy in high-risk groups, strong family history and so on, I certainly do not believe in prophylactic mastectomy. I feel, again, very strongly about the cooperative clinical trials. I think it is the obligation, the moral and ethical obligation of every surgeon to participate in such trials, his obligation to give his patient the best therapy possible. It is his obligation to help determine what is the best treatment possible. And it's a travesty, it really is, that we cannot get on with these studies and within 36 months or 18 months solve some of these problems that we've been kicking around for so many years. I would hope that all of you here would really assume a feeling of responsibility about clinical trials. There's a very frustrating question that has just been given to me. Is the panel unanimous that we should give up radical mastectomy as standard treatment for breast cancer? How about that?
Barney?
Well, I would vote that we should, because I think we can, when the time has come to reverse the usual thing. Everybody says, well, you've got to prove the simple way better. That's not the way things work. You've got to prove the bigger operation and the one that causes the more morbidity better.
How many in the audience do radical mastectomy as your usual method of treating infiltrating carcinoma? Raise your hands. You can see how the trend is at the present time. Maybe most of us don't know what we're doing, but that's what most of us are doing.
Well, now, if I could have the last word on this thing, I think this is exactly what has happened in the past, and this is what I'm trying to fight in the future. We don't make these decisions on what is appealing or what is logical. This is no way to make a decision about the treatment of breast cancer. And if you ask me, how do I treat breast cancer? I know how I treat breast cancer, but I submit to you that it is of no moment to you. It is my personal opinion, and that's all it is. I have no divine message as to the correct way to treat breast cancer. And that is why I believe that all of us must get these clinical trials done as quickly as possible and not sit on our butts and continue year after year to go through this same type of masturbation.
I think Bernie really ought to ask you fellows how many of you are willing to personally put your patients in such a study, because it's rather difficult. Every time this comes up, you get around to where you're going to get patients to handle a study of this sort. I know of no well-controlled study of this sort that is done. Surgeons have opinions, and they follow their opinions pretty strongly. It'd be pretty hard to randomize what Dr. Cryle has said or what any of us have said, as a matter of fact. Actually, at this time, there is a study going on in Scotland, a follow-up on McWhirter's study. It's been done under the direction of Sir John Bruce. I asked him what's going on with this study. He's got about 400 patients each in a random control study evaluating simple mastectomy plus irradiation. Now, this is a little different from what Dr. Cryle had said, compared with standard radical mastectomy. He tells me that so far, in terms of survival, there's been no significant difference between the two methods, but every year the bias has favored radical mastectomy. It's been going on about 8 years. This report will be completed within the coming year. It may be there will be some statistically significant information based on this type of study. Simple mastectomy alone, unfortunately, without irradiation, was not included. Our time, I believe, is up. Thank you all for your participation. I'm sorry we couldn't answer all the questions.
And this concludes this first edition of Audio Digest Surgery for 1971. The editors express appreciation to the speakers and to the Board of Regents of the American College of Surgeons for cooperation in recording and disseminating this material. Audio Digest Surgery is produced and copyrighted twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association.